To be here. So we're going to go over an interesting case. During my fellowship, I found some of the most rewarding cases have been those that are patients that are told they have no other options, and other also ones where it kind of becomes a little bit of a puzzle during the case, and this kind of fulfills both of that. So no disclosures. A little bit of a complex past medical history, so we'll spend a little bit of time on this. She's a 78-year-old woman, history of severe AS with an ascending aortic aneurysm, underwent surgical aortic valve replacement with a 21mm Edwards Magna bioprosthesis, as well as an aneurysm repair that was primarily just a resection that was done in October. She also has AFib on warfarin and has a prior stroke, and then subsequently had a DVT and a PE while on warfarin, and so her INR goal was elevated a little bit. 1 month post-procedure from that valve and aneurysm repair, she presented with an acute type A aortic dissection, underwent emergent surgical repair with a 30mm hemishield graft via circulatory arrest and hemi-arch replacement. Intra-op, they found a 1 centimeter tear adjacent to the aortotomy suture line in the right anterior ascending aorta. Then 2 months post-op after this procedure, presents with a chest wall abscess, mediastinitis, and had to undergo wound debridement and wound vac placement. Was in the hospital for a little while, but was able to recover and ultimately returned home. Then now, 5 months post-op from her original procedure, presents to an outside facility with chest pain. A CT was done, it wasn't gated properly, and it was initially read as a possible aortic root hematoma, but the arterial phase was unenhanced, so then she was transferred. We opted to repeat the imaging, and we saw a large anterior contained aortic root rupture with a pseudoaneurysm. It was so large that it was causing compression of the distal aorta as well as the carina. Cardiac surgery was initially consulted. They felt that a second reduced sternotomy was felt to be too high risk for this patient, in addition with a possible active infection. So the structural heart team was consulted to evaluate possible percutaneous therapeutic options. Of note, the patient was very interested in aggressive therapies and wanted to keep moving. Chest x-ray, mostly just notable for a widened mediastinum. CT was done, and you can see the large pseudoaneurysm here with about a 12.8mm neck right there. Of note, the aorta was particularly tortuous, and so this required a little bit of pre-procedure planning. We knew that both support and catheter lengths was going to be important. Her transthoracic echo here shows communication. Oops. It's not working, but there's flow into the pseudoaneurysm there. So the procedural plan, we had a large contained anterior aortic root rupture with a pseudoaneurysm with a small os. We did feel that it was appropriate to at least attempt closure. Granted, this would be a very high-risk procedure. We had a long discussion with the patient and her family, and they were aware of the risks and willing to proceed. Planned with the transfemoral retrograde arterial approach with the very tortuous aorta, as I mentioned, keeping in mind support and catheter lengths would be notable. The hope was then we could carefully wire the pseudoaneurysm via the neck and then deploy an ASD occluder device, make sure we don't have any interaction with the coronary ostia, and then do all this under TE and fluoroscopic guidance. So this picture, we didn't have any fluorostors, but in order just to get to the os was incredibly difficult. We started with just usual JR, multipurpose, and AL1 catheters, trying to wire with an angle glide. Having trouble navigating to the neck, we put in long sheath, first a 55 centimeter bright tip and then a 70. We were ultimately able to get there with the 70 bright tip sheath inside of with a 7 French JR catheter and a 5 French multipurpose inside of that, and then an angle glide. We've had some nice intra-op images here with the communication into the aneurysm there. Here's a nice picture using a super stiff wire. We were able to get the wire in through the os and into the pseudoaneurysm. I have a cine film coming up that shows this a little bit better, just how big it is. And the echo shows some nice pictures here with the wire inside the pseudoaneurysm down below there. We were able to get, ultimately, we first tried with a 8 French torque view delivery catheter, which was too short. We had to take that out and put in an 8 French flexor shuttle sheath. Took a little bit of rigging, but we finally were able to position it and got the 16mm ASD device in place. Again, this was all under echo guidance. And get the picture here. Shows the device being pulled into place there. And we did take, again, I have a picture coming up that shows that the device was well seated and the flow had immediately decreased into the pseudoaneurysm. And we checked with Doppler color, Doppler as well, showed decreased flow into the pseudoaneurysm with the device in place. we checked the coronary arteries, everything looked good, and so we opted to deploy it. And this last film here shows, it's a nice summary. So this is pre-procedure or pre-device deployment. You can see flow into the pseudoaneurysm here. Injecting directly into it, you can see just how large it was. And now with the device in place, the flow is significantly decreased. Go ahead. And we did do a post-procedure CT that shows the device in place. A thrombus was already forming within the pseudoaneurysm. There's a nice 3D picture of the CD with the CT with the device in place. And so in summary, we were able to successfully close the pseudoaneurysm via transfemoral access. It was quite difficult, but there was no interaction with the coronary arteries, and the flow decreased immediately. Just a couple learning points. Very high morbidity and mortality if you do approach this surgically, but we were able to get there percutaneously with a nice durable result under imaging, which has been shown in a couple other case reports to be vitally important, as you would guess. There is also one report that even as far out as 3 months, recanalization is reported, so monitoring is important here. Excellent. Thank you.
Questions for Jonathan? I'm familiar with this case, so
I don't know much about this, Paul, and this is a great presentation. I just want to have all of us know this is not the first option. This is right. Most of these patients would get surgical in heavily comorbid conditions. This is something you would consider. Is that the message?
Definitely, surgery would normally be your first choice, but this would have been her second redo, and it was also thought this was secondary to infection, and so the surgeon just didn't have any desire to take her to the operating room.
I mean, actually, these are. Go ahead, please, Mazen.
Just a quick question: how do you size the occluder, like based on the CT? Because these come with significant.
Yes, so we used the CT as well as we did intra-op sizing with the TE. There is a concern that if you oversize, you might, things might really go poorly. But we got lucky, and she.
Just 1-to-1?
Yes, well, we went a little bit larger. I think so. On the CT, it was 13. On the TE, it was 14. We put in a 16 millimeter device.
So can I ask you, is there a chance of this dislodging or causing erosion? I know in the SD you may, but is there anything like that, or I guess it doesn't matter?
I haven't seen that in reports, but that's obviously not something you really would want to publish. So maybe it happens.
Good point.
Shouldn't be, because it's relatively immobile compared to ASD closures. But thank you.
Thank you.
Thank you, John.
very much.
Yeah.